Thanks everybody for joining us. These series of lectures and webinars that we've been running for the last few weeks, the feedback about them has been really positive, which has encouraged us to keep on annoying you with more and more webinars. Nearly everybody has webinar fatigue at this stage, but the appetite seems great. Dan Ryan, of course, has been the main driver behind organising these webinars, and he himself unfortunately is unwell and couldn't be with us, and had the misfortune of entrusting it to me for today. But I'm really glad to say that this is one of those weeks where we have a stellar presenter, and really interesting to get that UK perspective. And as you were saying, Adam, as we were coming on, it's nearly more important than ever, given the pressure that's on our sector, and on the nursing home sector at the moment, to have a look around and to just take at least some stock of the fact that the significant impacts that we're seeing isn't just ourselves. But Adam Gordner is Professor of Older People at the University of Nottingham. He's a practicing geriatrician. He's been conducting research in care homes for over a decade, and has recently been involved in writing up the national guidelines to help steer care homes through COVID on behalf of the British Geriatric Society. He helps to support an online community of practice for UK care homes focusing on COVID. Similar to this our own webinar series here, I'm sure, and we're really delighted to hear your presentation this morning. So thanks very much, Adam.
Hey, thank you very much, Sean. It really is a pleasure to join colleagues from Ireland to discuss what's going on in the care home sector in both countries, what we can learn, and I think, as you said during your sort of introductory chat, one of the most interesting things about this is how rapidly things have changed in the care home sector in the UK. I'm sure there are similarities with the situation in Ireland, and I think one of the important things at the end of this will be how we can take some shared learning forward to ensure that we continue to drive up standards in the care home sector and in healthcare support to the care home sector. I'm going to share my screen. Hopefully you can all see that now, and I'm just going to talk for a few slides that sort of really gives an outline of the challenges we've been facing in the UK care home sector since COVID started. My perspective here is that I've been working with and doing research in the care home sector for over a decade now, and I'm always a geriatrician at meetings, annoyingly saying, and what about the care home sector? And I've very much gone native over my long period of time working with them. And at the beginning of COVID, I was approached by some care home managers who said they wanted to set up an online community of practice, slightly different from this one. It was to be a sort of responsive community of practice based on WhatsApp in the first instance. And within 48 hours, we'd gone beyond the maximum capacity of WhatsApp. We had 250 members and discovered the numbers didn't go any higher, and we had to actually develop a different platform, which is now an app which people can access from their phones, so that we could keep the discussion going. And the wider platform has over 1,000 members, but it's worth saying that the WhatsApp thing continues to go on, and it's pinging 24 hours a day, and you sometimes go on a ward round and come back and find that there's been 30 interesting discussions that's happened. But I think that's been really useful in terms of staying in touch with what's happening in the care home sector, and pretty much everything that I'm saying today is been informed by those discussions. My other role, just to give you a sort of slightly different view on my view on this, is that I wrote the BGS guidance for COVID in care homes. I'll talk a little bit about that during the talk. And I've also been acting as a British Geriatric Society spokesperson on care homes through the crisis. And so I've had a lot of dealings with national government bodies as well. So I have both the frontline care home perspective, but also the perspective of the people in the centre that are trying to plan the response. And I think the most balanced thing to say is that both people are trying very, very hard to do their best through this. Most of you will know quite a bit about the UK care home sector, but just to give you a flavour for those of you that don't know it very well, there are about 430,000 residents in UK care homes across 450,000 registered beds. About a third of those are nursing homes, which means that they have a nurse on the premises 24 hours a day. The other 2/3 are residential homes, so have no nurses within their core staff. the difference between the residents in nursing and residential homes is actually not that great, and so there's very high dependency and complex medical problems even in UK residential homes. The care home sector is about 3 times the size in terms of bed base of the UK acute hospital sector. So when you think about this in terms of COVID, how those two sectors interact in terms of maintaining capacity in the system is really quite an important calculation to ensure that the system can meet the needs of older people through the COVID crisis. Almost all residents living in care homes have multiple long-term conditions. So the average number of conditions for a resident living in a UK care home is 6, and usually 3 of those will be long-term conditions. So the medical management in the sector is quite complicated. The providers of UK care homes are largely not state-run. Only about 8% of care homes in the UK are owned by a local authority or the NHS. The other 92% are owned by private providers. But about 50% of care is reimbursed by the state, so it's either paid for by local authorities or the NHS. It must be said that there have been long-standing issues about the level of reimbursement, and particularly local authority reimbursement, maybe just around the actual cost of care. So particularly smaller providers do sometimes struggle with profit margins, and that has posed some challenges through the COVID crisis as resident bed-based numbers have gone up and down quite rapidly, and often providers have had to put out quite a lot of money for PPE, but I'll come back to that later. Healthcare to care homes is variable, so it's provided by general practitioners, but actually coordinating the general practitioner input to care homes in a meaningful way was actually part of something called Enhanced Health and Care Homes, which was supposed to be enacted this year, and so it's been on the to-do list rather than being something that's been fully completed. And it's also worth noting that we have no minimum data set in UK care homes. So my understanding is that in Irish nursing homes, there is a minimum data set which is based around the inter-RAI. You can correct me if I'm wrong when we get to the Q&A. There's no equivalent minimum data set in UK care homes. So there has been historically no way to collate data from the long-term sector. That was where we were at the beginning of the outbreak. Lots of things have happened during the outbreak. These are the things that I'm going to touch on briefly over the next 15 minutes or so in terms of topic headings where we've learned a lot and had some really important experiences to share during the outbreak. The first of those I'll touch on is advanced care planning, and it takes me to the British Geriatric Society guidance on managing the COVID-19 pandemic in care homes for older people. Right at the beginning of the pandemic, Public Health England and the Department of Health were quite slow to come forward with guidance for care homes, and so the British Geriatric Society wrote guidance to try to plug that gap, and the aim was for that to be practical guidance that could enable care homes and general practitioners to start to plan care. And a really central part of this, it wasn't the only part, there were lots of aspects to this, including how to support people in situ and when to escalate them to hospital, but quite a central part of this was advanced care planning in care homes. Why was advanced care planning important? Well, many residents living in UK care homes are near the end of life. The average life expectancy in a UK nursing home is about a year, and in a residential home is about 2 years. And people go into care homes for a reason. They have significant dependency, disability and long-term health problems. In the context of a pandemic, it was in the media, many residents and their relatives had started to think about what they would want to happen if their health was to get worse, and therefore it's important for us to be having discussions about escalation. And that's important because some would choose not to go to hospital, and we can only recognise those wishes if we've established them and documented them. But it's also important because some people would choose to go to hospital, and we can defend that stance much more effectively if we have that documented in an advanced care plan. So there were very sound reasons to want to focus on advanced care planning earlier in the pandemic. This was challenged by a number of things. One was that care homes went into lockdown quite early in the UK, and a lot of healthcare professionals who would normally do in-reach into care homes stopped going in. And so we ended up doing, or trying to do, large amounts of advanced care planning remotely. So you had GPs trying to do them using iPads and FaceTime rather than using face-to-face discussions. And that certainly challenged a lot of the human aspects of advanced care planning. The other thing that went wrong was when some healthcare practitioners misinterpreted quite what was required with advanced care planning and trying to do it in a blanket way. Their understanding was that this was around resource allocation rather than around personal wishes, and that got quite a lot of negative press. The other thing that went wrong is when too much emphasis was put on care home staff, and particularly in residential homes where there might not be qualified nurses. Care home staff often found that they were being asked to have quite detailed advanced care planning without enough medical support, and that was also an error that happened in a few places early in the pandemic. It must be said that for the most part medical support was made available and individual discussions were had, but where things happened clumsily they got into the media, and that has made it a bit more difficult even for those of us that have been trying to do it well. I'm just trying to advance my screen, which seems to have frozen. Here we are. Just to give you a couple of examples of how these things hit the media. This was an example from the Manchester Evening News about elderly people with coronavirus being denied hospital beds and left to die in care homes. And the geriatrician who had been out doing advanced care planning in the care home that formed the basis of this subject phoned me up the following day to say that everyone in the care home was entirely happy, and the care home manager was happy, and the relatives, several of them actually sent him cards afterwards to thank him for the considerateness with which he approached the advanced care planning. But when the local MP got hold of it, suddenly it was fodder for the Manchester Evening News. So even when these things are done well, the media have been catching hold of them and sometimes distorting what's going on. But there have equally been examples of things being done badly, and there have been a few examples in the UK of general practitioners sending out blanket letters to people both in care homes and in their own homes about do not resuscitate orders. Those have elicited apologies. The negative media coverage of those has been appropriate, but it has made advanced care planning slightly more difficult and more controversial for those of us that have been doing it correctly and appropriately. I mentioned that early on in the pandemic there was very little focus from Public Health England and the Department of Health on guidance for care homes. And in fact, the one thing that they did produce that mentioned care homes, you see this is dated 19th of March, was actually a hospital discharge service requirement, and the single mention of care homes in this was that they had to keep their doors open to hospital discharges at all costs. And I think that reflects a lot of the early central thinking around COVID, which was that hospitals would be overwhelmed in the way they were in Italy, and therefore keeping the system moving was a primary priority. There's now a lot of debate about whether it was correct to keep care homes open to admissions earlier in the pandemic, and that's maybe something we can discuss during the question and answer. It took them almost a month to actually produce specific guidance around admission and care of residents during the COVID-19 incident. You can look up both of these documents online, but it was really a month until the care home sector got specific guidance on isolation. The current guidance for UK care homes is that for those residents that are entering the care home who are either symptomatic or have a COVID positive swab, then they're to be isolated in the care home for 14 days. But many care homes are saying, well, they don't think that's enough, and they've decided off their own backs to just isolate all residents that are coming into the care home for 14 days. And in many ways that seems sensible given what we now know about the fact that many people are asymptomatic but still spreading potentially the COVID virus. These same isolation processes are in place for residents in the home if they become symptomatic. Now, I mean, there's been a lot of guidance coming from around Europe suggesting actually maybe residents should just be managed in their care home bedroom during the pandemic. And certainly the latest iteration of the British Geriatric Society guidance suggests that people might want to be managed in their bedrooms as much as possible. But I think we have to be aware that that comes with a number of challenges. If you've got relatively small staffing ratios, putting people into their bedrooms challenges supervision. How do you stop people from falling or coming to harm if they're usually supervised in a common area? There are issues with people becoming socially isolated, lonely and depressed if they spend all their time in their bedrooms. And we're now getting reports from care home staff in the front line that a number of residents who have spent a lot of time in their rooms are becoming quite rapidly deconditioned and not able to walk around or fend for themselves as well as they did at the beginning of the outbreak. So I think that's a great way to prevent spread of COVID, whether putting people in their rooms and keeping them in their rooms when they don't have COVID is good for their overall well-being. I think the jury is still out on that one. One possible solution to this has been featuring on the LTC COVID platform. This is a research platform bringing together research from around Europe into long-term care. And this is from a group called Bushproof, who are an infection control advisory group. And you can see this is the sort of thing that they're recommending about maybe residents can have more movement within homes if staff are able to effectively zone a care home into green, red and amber areas, the sort of thing that's practiced in many hospitals. We have amongst this network of care homes I'm supporting some homes that have been very easily able to do this because of the configuration of their home. They have separate lounges and separate entrances, and so they can easily do this. Other homes which are in residential properties with a single entrance off the street struggle. But certainly a number of homes report being successfully able to do this, and this is one way that they've found to overcome some of the issues of isolating residents in their room. I think that's been prominent in the media in the UK has been access to tests. Public Health England did not prioritise care home residents for access to tests earlier in the pandemic. Again, the focus was very much on ensuring that we had enough test capacity in acute hospitals to swab people who were coming in with COVID symptoms. And so early in the pandemic, the guidance was to isolate people. Sorry, I've typed that incorrectly. This is what you get for preparing your slides on the morning. Isolate people if symptomatic, but without a swab. Through to a few weeks later when this was starting to hit the media, well, up to the first 5 residents will be tested, but thereafter, when it's confirmed that there's COVID in the home, everyone else should just be managed as if they have had COVID. And again, with ongoing media pressure, coupled, it must be said, to increasing capacity within our testing system, our Secretary of State for Health and Social Care announced on Tuesday this week that we would be having blanket testing of all UK residents and staff. So that's effectively to say that over the next week or so, we should have pretty much everyone in the long-term care sector, staff and residents, swabbed. We're getting variable reports back from care home staff about the rate at which that's happening, but some are reporting that it's started to happen in their care homes. The challenge, of course, is once you've blanket tested everyone this week, what happens next week, and how do we know that there's not asymptomatic carriers in the care home a week from now? And nobody at either Public Health England or the Department of Health have come up with a solution for that particular conundrum. So I think that's the next thing that we're going to have to tackle as we move forward to try to really develop a logical and coherent response to testing. So we're going from no tests to lots of tests, but we still don't quite have a coherent strategy about how those lots of tests should be deployed. We didn't until probably about a week and a half ago start properly counting COVID infection or deaths in care homes. This is a graph which is on the web page of the English Office of National Statistics. There's a separate graph for Scotland and Wales because they have different statistical bodies. But I think the key point is if you look at the last week or so, there's an effective doubling in the number of deaths from COVID in the care home sector. And that doesn't represent a rapid increase in deaths in the care home sector. It represents a rapid increase in reporting of deaths from the care home sector. That's probably a consequence of what I said before, that historically care homes have not had a minimum data set in the UK, and we haven't had mechanisms for reliably gathering data on care delivery or indeed morbidity and mortality in care homes in the UK. And we've had to rapidly develop this through the crisis. And you'll see that this is reported, it doesn't say, but this is reported through the Care Quality Commission, which is usually a regulatory body which has started to just collate these data during the COVID crisis. But it does mean that the headlines have changed. So this is a BBC News article from just the day before yesterday saying that with these new figures, a third of all coronavirus deaths in England and Wales are now happening in care homes. The data from Scotland suggests that their figures are now up to half of all deaths. And I suspect that as the reporting improves across England and Wales, we'll get close to that as well. Certainly the data from across Europe ranges from about a 35% proportion of deaths in the Netherlands to about a 57% proportion of deaths in Italy. And there's no reason to think that when the UK gets its death certificate reporting sorted, that it won't be in a similar sort of region. Personal protective equipment has been a big issue. I think one thing that's important to say is that the guidance for care home staff has mirrored the guidance for NHS staff throughout. So care home staff have been told to wear the same protective equipment as NHS staff. There's also been an extent towards which both NHS staff and care home staff have had PPE that has not been in line with World Health Organization requirements. So I've just come from my COVID ward and I still wear a standard surgical mask that goes around my ears and not an FFP3 mask, which was the World Health Organization guidance early on in this crisis. Care home staff did start to get a bit paranoid quite early in this. They're a bit worried early in this that NHS staff were getting access to high-tech kit that they weren't getting. And what the real reason for this is that they were looking at newspaper reports or what they were seeing on Facebook and Twitter, where NHS staff were posing in full-body gowns and masks and FFP3 masks, and not realising that those were ICU doctors or nurses or consultants doing aerosolising procedures. So through our peer support group, one of the things we've been doing is trying to correct the urban myths that there's a difference between health and social care. Actually, we've both been equally probably underprepared in terms of the PPE that we've been using. Having said that, care homes have been disadvantaged in one way, which is with relation to supply chain. In the UK, care homes are usually outside the NHS supply chain, and the NHS in the UK is a massive purchaser, and it very quickly became the monopoly purchaser of PPE in the UK, to the extent that care homes were waiting for a delivery of the PPE that they were expecting and finding that it had just been bought out by an NHS trust and reallocated to an NHS organisation. And the only way around for that was for care homes to go online and buy it through private providers at inflated prices. The NHS said it would provide PPE to care homes, and it said it would do this through an online tool called the Capacity Tracker, but it took us a couple of weeks for the majority of care homes to get onto the Capacity Tracker, and during that sort of period of time there was a bit of a Wild West economy where care homes had to fend for themselves. And even now we're on the Capacity Tracker, there's a sense at which the PPE is not arriving at care homes quickly enough. The care home managers I know that have had an outbreak have described it going from one case to perhaps 8 or 10 cases within a 24-hour period, which means that their PPE requirement's gone up by a factor of 3 or 4, and yet it might take them a day or two to get the PPE that they actually need. And so we're still trying to move towards a situation where care home staff can get PPE within hours rather than days, and that really is the holy grail that we need to be moving towards. I mean, if Amazon can get your parcel to you within 12 hours of it being ordered, we would hope that we can move towards something like that for the supply chain for care homes. Just to give you a flavour of how desperate this got, this is a colleague of mine who's not working in care homes but is running a domiciliary care agency, and she was quoted in The Guardian saying that she was paying £11.95 per mask, and she could only buy masks in lots of 1,000. And I mentioned at the beginning how private care providers that run, especially the smaller ones, on quite small profit margins have found that their business model has been taxed enormously by this crisis. And one of the issues we do face coming out of this is how many of the care home businesses will be in a good state to keep delivering care going forward. And we've yet to find really reliable ways of reimbursing these care homes and domiciliary care providers for the outlay that they've had to put out to actually provide and buy this PPE. The last thing I just wanted to talk about was enhanced healthcare support in care homes. And as geriatricians, we've been sort of banging on about this for a while. This is some British Geriatric Society commissioning guidance from 2013 that said that there could be times when subcutaneous fluids might be useful in care homes. And up until this month, this has largely been parked in the too difficult to implement category for most care homes and NHS providers in most parts of the UK. But suddenly we're getting movement on this, and there's now in a number of areas been examples of general practitioners working particularly with nursing homes to put oxygen and subcutaneous fluids in place. This is not for people who appear to be end of life, but really for the sort of people that might go to hospital and benefit from oxygen and subcutaneous fluids, but in some instances would rather stay in their care home, and in some instances would feel safer staying in their care homes. It's likely that we'll see national guidance coming out in the next couple of weeks that this should be part of extended scope practice for care homes more generally, and that's a very significant shift from something that was in the too difficult to contemplate category just a month and a half ago. Maybe finish on a bit of good news, which is one of the things that has come out of this has been a rapid reassessment in the public eye of the status of the long-term care sector. Up until recently, care homes largely only featured in the media when there was a scandal, someone came to harm, there was an abuse or neglect story. And of course that was representing the minority of what was happening in long-term care, and there was a lot of excellent care that largely got overlooked. And care homes were still in the periphery of this right at the beginning of the COVID crisis. So the first week we had a clap for event. We have these every Thursday now in the UK. Everyone goes out to their front door at 8 o'clock PM and claps and bangs drums and plays trumpets, and it's a way of raising morale and showing support for people providing care. And the first week we did it, it was called Clap for the NHS, and we largely forgot the long-term care sector. I claim no ownership of this, so the we is a collective national we, not me personally. But by the following week it had been iterated to Clap for carers, and it's now very clear that care homes are grouped in the public consciousness with the NHS as being part of the critical response to COVID in the UK. And the media coverage during this has actually been unprecedentedly balanced. I think we're seeing a very sensible discussion about what's happening in long-term care rather than the more sort of blamey type of discussions that we saw in the past. So just to finish, what is it that we need to hold on to as we come out of this? Well, we've done a lot of work to integrate the supply chain. You've heard from me that there's still some work to do, but we do need to hold on to that progress and make it even better as we come out of this. We've made lots of progress in collecting and collating data from care homes, and we need to build on that once COVID is over. This business around being able to provide augmented healthcare support to care homes, oxygen, fluids, antibiotics is required is new, but it's been long recommended, and it would be interesting to see if we can actually hold on to that and build on it as we come out of the crisis. But I think above all it's been the recognition of care homes, their staff and the people they care for, and I think my hope is that that will be a burning platform for people like me and other people that have a national role to campaign for improved governmental funding for long-term care, and also improve recognition of the grassroots workers providing care in care homes in terms of salary and also training and recognition. So that's a summary of the challenges, dilemmas, difficulties we faced over the last month and a half. It feels like about a decade in my recollection, but it's only been a month and a half, and I'm very happy to discuss further or take questions. I shall stop sharing my screen now.